Good morning and welcome to my channel, Pain Free Partha. Today's topic is about deliberate hypotension or controlled hypotension, where we will use what is the problem with some simple technical examples. Okay. Now, what is this? Deliberate hypotension is a state of induced hypotension. We are inducing BP to fall, but also we are controlling how much BP should fall. These are the two words. One is it is induced. Another is we are controlling the BP fall. What is it used for? To decrease bleeding, to improve the surgical site visibility. Okay. Now, what should we do? We should know the pre-op blood pressure. We cannot do the same thing for a BP pre-op of 140/90 or 110/70. We should know what is the patient's age and what is the past medical history. For example, a patient with stroke earlier may come. In 1946, they started an arteriotomy, and they went on to give high spinals and high epidurals. Then the first was SNP, and slowly the newer drugs have come. Reduction of the systolic BP to around 85 and reduction of MAP to around 60. 30% reduction of the baseline MAP. Maybe around 20-25% was a chronic hypertensive attacks. Now you see here, on the map, for example, MAP is 80, 30% reduction. Maybe around 60 it has come down. This has come down. This we should not come down to so much in chronic hypertensives on drugs. Get around 20-25% less only. Now, what are the indications we use it for? Scoliosis, revision hip surgeries, pelvic malignancies, major vessel surgeries, reconstructive spinal surgeries. So many indications. I will give you in a nutshell later. Complex neurosurgeries, pituitary, intracranial malformations, microsurgery, plastic middle ear, vessel grafts, intraocular surgeries, vitrectomies. Now we go back to indications now. What is spine? Everyone knows what is spine. Yes, spinal surgeries, pituitary, pelvic and plastic surgeries, intracranial and intraocular surgeries, neuro and neurovascular surgeries, ear and endoscopic sinus surgeries, ear and endoscopic surgeries. So we got spinal surgeries, pituitary, pelvic and major plastic surgeries, intracranial and intraocular surgeries, neuro and neurovascular surgeries, ear and endoscopic sinus surgeries. This is what are the indications of controlled hypotension. There is something we call as hypotensive resuscitation. Give fluids in trauma to maintain an adequate proper perfusion with a systolic BP of 90 and mean of 60 to 70. Not much of aggression, because we are worried about dislodgement of blood clots and we are worried about dilution of coagulation factors. Now, why we need controlled hypotension? Yes, two things is very important. Number one is surgical bleeding causes more morbidity than deliberate hypotension. It is been proved. So bleeding causes more problems than we do deliberate hypotension. Now, what is the basic principle? Now you understand the basic principle we are operating here. You decrease the blood loss here. But what we should not do, we should get the flow blood into the brain and the heart from the kidneys like this. This is the idea. Decrease here, but maintain flow here. Somebody asked the idea of controlled hypotension. This is the idea of controlled hypotension. Deliberate hypotension could shorten the surgery time, could reduce tissue edema, could reduce pain, could improve myocardial performance. Need of blood is decreased. Better field, better operation, less time, less blood loss, less pain. These are all the advantages of controlled hypotension. Ischemic stroke, so contraindication. Subarachnoid hemorrhage, untreated hypertension, don't go. 180/110, already it is Don't go for controlled hypotension. Get it below well for few weeks and then come back. If you want controlled hypotension, peripheral vascular disease, fixed cardiac output states like mitral stenosis or aortic stenosis. Already there is a hypovolemia. Pregnancy, no. Glaucoma, no. Patient is already anemic, 8 grams. We don't call it as 10 grams here, but it is usually mentioned as 10 grams. So these are all the contraindications of controlled hypotension. Somebody may ask, ischemic stroke is there already old and now the patient is coming for some surgery or scoliosis surgery or something like that. Yes, we should be very careful about or some minimal contraindication of hypotensive anesthesia. Now we know MAP is cardiac output into total peripheral resistance. Cardiac output is by heart rate into stroke volume. Now we can decrease here total peripheral resistance by vasodilators. The MAP will decrease. We can decrease heart rate by beta blockers. We can decrease stroke volume by decreasing preload and decreasing contractility. So we can have decreased contractile drugs, we can have beta blockers, we can have vasodilators. So our aim is to decrease. Techniques which can reduce blood loss. Yes, we can blood loss, but there is no, this is not deliberate hypotension. What are they? They are local with adrenaline. If you give local with adrenaline, it will decrease blood loss. If you put a tourniquet, it will decrease the blood loss. But IPPV, PEEP, position, all these things are not very classical of deliberate hypotension, but they are usually included in controlled hypotension or deliberate hypotension because the main aim is to decrease blood loss. Now, position and bloodless field, you can see here, this is the problem, this is better. Now, this is better. Now, a suitable patient. So, the patient should have an indication. What the indications are? Sprained. You should not have contraindications. Ischemic stroke as a suitable patient. Uncontrolled hypertension. No. BP is okay. Now, we create a stress-free induction. Pucker position. Good fluids. Then the BP is okay. Start isoflurane. Get down. Then if it is not good, then you start first line hypotensives, second line hypotensives, and slowly withdraw. Second line, first line, isoflurane, then extubate. Keep MAP at around 60. Why? Because we know autoregulation is around 50 to 55. If you don't know anything, if the BP is 130, 85, keep down systolic maximum 85. Diastolic is systolic. There are a lot of drugs, neurological depressants, volatile anesthetics, IV anesthetics. We can give propofol infusion to decrease and control the hypotension. We can give vasodilators, SNP, NTG, adenosine, etc. Indirect trimethophan. We can give cardiac depressants, beta blockers, calcium channel blockers. Position, I have already told, hypothermia can cause cerebral vasoconstriction. Renal circulation, this is 70 to 75 MAP. Hepatic circulation, there is no autoregulation. In respiratory system, pulmonary blood flow goes down more to dependent areas. So your vasodilators will decrease HPV. Now you see here, blood flow is going somewhere. The vasodilators is cut down HPV. There is a problem of hypoxia. Inhalational agents establish anesthesia, rapid onset, rapid offset. Isoflurane is ideal because it decreases SVR. There is no myocardial depression. Halothane is okay, but it is gone. 2 MAC isoflurane start rapid onset offset. SVR decreases. There is no myocardial depression. There may be mild tachycardia, but no to enflurane. Inhalational agents, we should remember that they may increase ICT. Now, we are planning a surgery for induction of hypotensive anesthesia for cranial surgeries. Now think that inhalational agents may cause problems. Before idea is the agent, then it's a problem. Sodium hydroxide SNP, the onset is fast, peak is in 2 minutes. 1 to 1.5 mics per kg per minute. Most of the times what happens is, I feel the Saline is taken in the syringe and it is flushed. Then most of the times we add SNP after that. The whole of the extra infusion set will not have SNP now. Okay. So if you start at 2 ml per hour, this will take some time to travel through the IV tubings. So flush the tubings with a 50 ml saline with SNP or with the nitroglycerin so that the drug starts to go to the blood immediately as you switch on your pump. Elderly, be careful. SNP. Rapid onset of titratable EC, but cyanide toxicity and rebound hypertension is very important here. One point of rebound hypertension. For example, if you do FES and SNP, and if you stop SNP, and when the patient goes to the ward and there is soakage of your so-called plaques. So that is what is important. More effect on capacitance cells, NTG, better in high HD patients. That is commonly used. 0.2 mics per kg per minute can go up to 1 mic per kg per minute. NTG is commonly used. Delayed comes as problem is it may cause increased tachycardia and shunt headache, dizziness in others. But this is commonly used. Start your NTG at 0.25 mics per kg per minute. Adenosine may have effect on this yeast bundle and produce conduction disturbances. Is almost not used now. Central vein is needed. Hydralazine IV, gradual and prolonged action. It will take some time to act. And prolonged action, it may take for 3-4 hours, which we don't want. We want onset and offset to be fast. As soon as you stop the drug, inhalation agents, it stops. Nitroglycerin, it stops. But sometimes labetalol may not stop. It will have to, as soon as you will stop the labetalol infusion, it may be going on. The action may be going on for 1 or 2 hours. This is what we don't want. So we had ideally a small infusion stop. But the problem is, if we have problems in cardiac output and bronchospasm, beware of beta blockers. Nicardipine infusion is available. Clonidipine infusion is available, and PGE1 is used mostly in Japan in neurosurgeries. So beta blockers and calcium channel blockers. Where magnesium causes an increase in blood flow to the brain. The middle ear surgeries are common candidates for hypotensive. The problem is we have to be very careful with NMG blockers. MAC self is anti-emetic is advantage in middle ear surgeries, but NMG blockers, yes, the prolonged colorization is a problem. As previously we said, we start the case with isoflurane, increase isoflurane to 2 MAC, then we start some drugs, then we start your NTG infusion, and this goes on. First choice, second choice, third choice, like that. Then it gives some amount of magnesium. So now people have slowly switched over to this drug, dexmedetomidine. It becomes the first, second, and third choice. Start with 1 mg per kg and prolong these things with 0.2, 0.3 mg per kg per minute. Hypotension, bradycardia is significant. But some analgesia is there with dexmed. Less agent, less secretion, there is less rebound hypertension. So dexmedetomidine is one of the major advantage. There is one more advantage with this. We can give it renal anesthesia. We can give it blocks. For example, if we establish a block of a sciatic nerve block or femoral combined, something like that, and start your dexmedetomidine. These are possible with this. So dexmedetomidine is slowly going off all these things. Who said dexmedetomidine? I can do functional endoscopic surgery with 2 different doses of fentanyl. Here they have given 2 mg per kg of fentanyl and then slowly give 2 mg, 1 or 2 mg per kg per hour. Then they did 3 mg per kg and they found out that is 2 mg per kg is good. There are people who said less than 60 is not acceptable MAP. Here you can see intraoperative meta-analysis is saying yes, 60 or 55 to 60 MAP is acceptable. Routine monitoring, pulse, blood pressure, ECG, sometimes EEG, ETCO2, urine output. I will always put a hand on the dorsalis pedis. If the dorsal speed is well felt, then cardiac output is good. That is one. Number two is urine out. So these two things which I'll be careful about. But sometimes we don't use catheters, urinary catheters for fist surgeries. No. So urine output monitoring cannot be done. Use IBP for rapid acting drips are planned for some time. For example, if you want to use NTG for 15-20 minutes, we need not use IBP. If the surgery is major, the hemodynamic disturbance is supposed to be more. And your controlled hypotension is going to be there for 1.5 to 2 hours, then preferably we can have an arterial cannula. This is what many people forget to say. Every time we can use a combination. Use the position, use some isoflurane and give NTG. Use isoflurane, fentanyl and local with adrenaline. NTG trimethophan, beta blockers NTG, fentanyl NTG beta blockers. Yes, it is not that every time we can use isoflurane and dexmedetomidine. We can use, it is preferable to avoid beta blockers with dexmed because bradycardia may be little more. So we can use a narcotic. If it is going to be there, we have to be careful about the bradycardia. We can always use isoflurane or calcium channel blockers along with this dexmedetomidine. So I will give you some tips. Very simple tip to have a successful controlled hypotension. Oral propranolol 40 milligram TDS followed by hypotensive anesthesia or AC inhibitors. Why? You know, as soon as you start your anesthesia and you start your controlled hypotension, the body does not want hypotension. It wants to increase the BP by doing two things. Number one is sympathetic stimulation. Number two is your ACE. What is that? Angiotensin mechanisms. These two things are stimulated. So unless you slightly down this, sometimes your so-called hypotensive anesthesia is very difficult to establish. So give some dose of oral propranolol on the day of surgery because propranolol is not a long-acting drug. It may act for 4 to 6 hours. Then start your induction. Or sometimes give some enalapril and start your induction. Then it is very useful because the surge by your anesthesia and surgery of so-called renin-angiotensin system is slightly suppressed, not much. This is what I want to deliberate hypotension activates catecholamines and renin-angiotensin mechanisms. So oral propranolol or oral captopril before anesthesia. Now we are told the indications. Spine is the indications. And how to start about, where, how much to give. Normally, it's around, keep the map around 55 to 60. That should be careful in patients with old age or any other disease. Major stroke, trauma, uncontrolled hypertension, all these things, no contraindications. How to give is start with your propofol, agent, narcotic, may be enough along with a block. Or sometimes we need to add an NTG or we may need to add a dexmedetomidine. This is common thing. Okay. Now we have complications. Very common complication is inadequate. You just start to give fist or anesthesia by coming down on the BP of 90-40. The surgeon will tell, no, bleeding is still there. I am not very satisfied. It is oozing air everywhere. So something is wrong somewhere. So that is inadequate. Dosage is a problem, tolerance is the problem. Sometimes it may be excessive. Now we have to maintain with the IV fluids and properly adjust the dosage of your hypotensive drugs. The other complications are cerebral thrombosis. My complication is mostly with an ENT surgeon, which he says even though it brings up to 95 to 42 or 90 to 52, he said this color is not white. But he uses adrenaline also. That is what I wanted to say. Use fentanyl, use isoflurane, use local with adrenaline, then give some Dexmed or clonidine. Hepatic failure, postoperative pulmonary dysfunction, rebound hypertension, and increased bleeding on the operative side. Dimness of vision, we have to be careful there. Anytime you have problems, yes, maintain vascular filling and optimized blood viscosity. You have a filled vessel and your blood viscosity is optimized, it is likely to flow and blood will go to all the areas. So even if it is small, aquatic area, your viscosity is less, your filling is fine, it will go to the thrombotic area into the brain. Effect of deliberate hypertension on regional cerebral during fits is MAP can be reduced up to 30%. PeCO2 is maintained. Heart rate should be above 60. So MAP decreased by 30%. But if the old age, MAP decreased by only 20 to 25%. Here you can say phentolamine is preferred over nitroglycerin. It is less harmful effect on cognitive function than nitroglycerin. What they say, phentolamine is better. Cognitive function is better in post-op. Problem with the surgeon is the surgeon wants good field, no bleeding. But the anesthesia are always our priority is patient safety, patient safety. So there are a lot of trials about surgical free, bleeding, all these things. But there are very less studies about safety outcomes. Improved surgical field and significant reduction, but no significant changes in hepatic function. This is a meta-analysis of hypotensive anesthesia. Now, how to recover vasodilators off, inhalational agents off? Yes, we have to be careful about rebound hypertension. There are two things which we need to manage when we switch off. Number one, give a narcotic, fentanyl, or give some ketorolac. The breathing is not a problem, platelet is not a problem. So your pain is controlled. Give an epidural, BP decreased, pain is still. Then take care of your hypothermia. These two things, if you do, your recovery is better. Hypothermia pain should not be there when you are doing taking off from your controlled hypotension. Use the natural hypotensive depths of anesthetic agents. Ideal hypothesis. Use the natural hypotensive effects of anesthetic drugs. Propofol is an hypotensive. Isoflurane is an hypotensive. Fentanyl is an hypotensive. Regional is an hypotensive. Spinal is an hypotensive. Use the natural hypotensive effects before you take your SMP, NTG, all these things. Naturally take natural anesthetics, so-called anesthetics are naturally hypotensive. Use them. We can give remifentanil 1 mics per kg per minute, propofol 200 mics per kg per minute as an infusion. Clonidine is can be given IV. Hypotensive anesthesia significantly reduces blood loss, transfusion requirements, and induced hypotensive is better than there's no additional blood swelling. Is almost equal to hemodilution methods. How to give ibuprofen? The answer is Viagra. What is this Viagra? Vasodilators, SNP, NTG, adenosine. Inhalational agents and IV anesthetics. Adrenergic blockers, labetalol, esmolol, and dexmedetomidine. Ganglion blockers and geographical position. Regional anesthesia like epidural and spinal. Airway pressure and peak. These are all. So whenever control hypotension, there are two things, spine and Viagra. If you write spine for indications and Viagra how to give, then you are in it. I will give a 30-year-old man coming for first surgeries. I will give in the morning of surgery oral propranolol. Start with fentanyl propofol position. I will always add blocks preoperatively. A 75-year-old spine. Now you see your BP cannot be come down. MAP is around 20%. Previously 30-year-old person, MAP can come down to 20% or less. Previous MAP is 50. 30% means 35. Now this is 60. MAP is only 20% can come down. Maybe around 50. So that is the problem when you are dealing with the old age persons. Can give an example, spine surgeries. Epidural with the GA, Dexmet with GA, always text the age, because we don't want patients to have cognitive dysfunction and on ventilator for 5 days after a spine surgery just because we have given one hypotensive anesthesia. We should understand that deliberate hypotension is for the comfort of the surgeon, and plan to do it with number one priority, safety of the patients. Remember spine and Viagra. Thank you all. Thank you all. Subscribe to my channel, Pain Free.